Good afternoon. Today my topic is dual mobility acetabular cups in obese patients undergoing primary total hip arthroplasty. Results from short-term follow-up. The demographics from the register in England shows that cementless total hip replacements have been more done in the recent years, and also mostly done in the obese patient in nearly 40%. Materials and method. Why did we study this? THR in obese patient is a challenging in terms of exposure, technique and alignment of the cup. It is growing concern as globally there is an increase in obese population. Higher incidence of complications following total hip replacement in obese patients like hematoma, wound complications, dislocation and failure of the implants and survivability of the implants. Obesity classification according to WHO, more than 25 to 30 years overweight and 30 to 34.9 class 1, 35 to 39.9 as class 2 and more than 40 is class 3. The implants used in this study are Avantage dual mobility 3P shell Jimmer biomet, which is manufactured from high nitrogen stainless steel and has a high porous titanium plus hydroxyapatite bone ingrowth surface. Initial cup stability was provided by the two tapered eggs which is put in the ischium and pubis, and also had a screw which can be placed into the ilium. Clinical review in clinic pre-op and then 6 months follow-up has been done over the telephone first year and annually after using visual analog score, UCLA and OHS at each point of contact. Demographics. Number of patients used in the study are 150 primary DHR with dual mobility from February 2011 to September 2017 and who has BMI of more than 30. The average BMI in this study is 37.5 and gender distribution, most of the patients are female 106 and male 44, and the side distribution and the age distribution, youngest being the 25 years and oldest being the 88 years. Mean average age of the patient is 64. This is a ASA distribution. This is a patient of 28-year-old female who has been done bilateral stage THR with dual mobility articulation. This is a 3-year follow-up X-ray which shows a good acetabular cup seating. And the results of intraoperative blood loss, lowest being 50 ml and highest being the 1400 ml. Average blood loss is 370 ml. The length of the stay is shortest 1 day and longest is 14. The average length of the stay is 3.2 when compared to the less than 30 BMI patient, it's a 0.5 day longer. The reasons for increased length of the hospital stay is one patient has bradycardia and perioperative cardiac dysfunction, 2 patients have post-op anemia, 1 patient with UTI, and 4 patients have prolonged physiotherapy and recovery. The mean follow-up following surgery is 3 years, longest being 7.5 years and shortest is 8 months. The pre-op VAS score is 8.8 and post-operatively developed to 1.6, and pre-op Oxford score was 9.2 and post-operatively it been increased to 44.5. Conclusions: there is no instability or no dislocations, and superficial wound complications requiring revisit to hospital are 3 patients, and symptomatic subsidence of femoral implant is 2 patients which is settled unrevised, and average VS scores improved from 8.2 to 1.6 after surgery, and the Oxford score from 9.2 to 44.5. The good functional outcome, none revised to date. Thank you.
Thank you.